Our data refute the information in the literature about the favorite habitat of Demodecosis in the skin affected by them. This view is contrary to the general biological laws. Any insects, while multiplying, colonized and occupy any vacant ecological niches due to their inherent adaptability. It's well known the mites, including Demodecosis, have inherent tremendous adaptability. What has happened? Why Demodecosis began to dominate after the elimination of pandemic classic scabies, which has been raging on the planet for 90.5 centuries. This fact is quite understandable in the existing literature according to the following information. At all times, all three genera of mites have been detected in the skin glands of patients with classic scabies, Sarcoptes, Demodex, Dermatophagoides. It's known that Sarcoptes pierce moves in the surface layers of the skin. Demodecosis live in the glands of the skin, and Dermatophagoides affect deep-lying tissue. As a result of specific local treatment of Sarcoptes scabiei, a patient with scabies was quickly sanitized due to sufficient availability of Sarcoptes to anti-scabiei drugs. But Demodecosis remained in a complex and deep-lying glands of the skin with tertious excretory ducts. There also remained sporadic Sarcopteses, which were subsequently the cause of the so-called acarian disease, carriage acariasis. Dermatophagoides were even more inaccessible to anti-mite drugs due to laying in deep layers of human tissues. The foregoing explains persistent of acarophobic or post-scabies itching of the skin after undergoing scabies, the complete absence of natural antagonists of microcosm, Sarcoptes, lysis, etc., and control of the part of the host allowed Demodecosis to flood all the ecological niches in the skin and the body of the human, and Dermatophagoides in the human's immediate environment, bedding, clothes, home, and so on, which we and other researchers detect presently. Thus, a pandemic era of sarcoptic mange was replaced by Demodecosis pandemic. Demodecosis was gradually gaining rate. In the 1970s, we recorded an avalanche spread of Demodecosis throughout the population. The consequence of the described fact, in our opinion, was a threefold doubling of the incidence of the earliest and the most frequent clinical mask of Demodecosis, that is allergy, which is fixed by allergists for 3 decades of the late last century. Our data indicate not just the ability of Demodecosis to cause the disease, but also about their high contagious. And this in turn means that if a family or a team has one patient with Demodecosis, blepharoconjunctivitis, or red acne, atopic dermatitis, etc., all its members in this outbreak are infected with Demodecosis. That's why in medicine blepharoconjunctivitis, discoid lupus erythematosus, or any other disease in which Demodecosis is leading or concomitant disease are not cured practically. For the same reason, when treating the face skin diseases, the problems with the eyes are arising, and this is proved by ophthalmologists. If Demodecosis affected facial or eyelid skin or any other area of the body, then Demodecosis is everywhere in this man, from the head to the finger ends of the feet and hands. And Demodecosis in the body of affected people live in colonies, which are earlier detected by our developed provocative method of detection of colonies. The denser of the skin is populated with mites, the more pronounced changes are in it. At heat rash, facial wrinkles, the punctate moles, large white or colony spots, loose skin syndrome, psoriasis, neurodermatitis, eczema, melanoma, atopic dermatitis, and other pathological conditions of the skin, potential candidates for anaphylactic shock or Lyell syndrome after provocation have Demodecosis colonies visible in the form of papular elements, being small as millet grain or larger, and with punctate excretory opening. Subsequent enucleating of parietal areas of these masses allows finding of them Demodecosis at different stages of development. Colonies of mites are arranged according to the specific structure of the skin glands of the affected patient. As you understand, we first carried out the mechanical cleaning of the skin of the patients affected by mites. You may ask, why not to immediately release the body from mites? First, we had to strictly comply with existing legislation in the field of medicine and only use approved tools and methods of treatment. Second, any drug, physical or biological agent could cause massive loss of mites in their places of residence in the body affected by them, and thus trigger the development of violent allergic reaction to the Lyell syndrome or anaphylactic shock. On the other hand, the remains of the bodies of massively dead mites while decaying could cause intoxication of the human body. To prevent these terrible complications, we firstly had to clean mechanically the largest organ, the skin of the human body, from mites, and then, with the less risk to the patient's life, to start cleaning her body of unwanted alliance, the mites. We recommend to follow this methodology till the legislative development of radical ways of treat Demodecosis and any other acariasis. The skin is most frequently affected at Demodecosis, and this is not surprising, since the inoculation of Demodecosis into the human body comes through the skin and the mucous membranes communicating with the outside. Cutaneous manifestations and complications of Demodecosis are detailed in the book we wrote in 1999, Allergy as a Cause of Growth of Human Diseases of the Beginning of the Third Millennium, Allergy, Acariasis. The second most frequent clinical masks of Demodecosis are allergic manifestations. And it's also not surprising, since any component of any mites bodies are allergenic for the human body. In the presence of a Demodecosis, any trigger that can cause massive death of mites in their habitats will provoke the allergic reaction. Based on the above, we can safely say that it's because of Demodecosis almost all allergists previously stated the development of allergies, first of all from the skin and mucous membranes. According to our data, the presence of allergy of internal organs means their affection by mites. Additional proof of this fact is, in our opinion, Demodecosis transition to anaerobic type of respiration that was described by some researchers. Knowledge of Demodecosis clinical symptoms allows hypothetically assume that all people of the world have the original white color of the skin. In the tropics and the subtropics, acrofauna is richer than in other regions. Therefore, the skin of the baby with light skin born from the dark-skinned mother is quickly gaining the appropriate color of his race. Unfortunately, at the present time, demodectic acariasis is so distorted that we already begin to observe the cases of intrauterine infection with it. as it can be judged based on the cases of newborns examination in the hospital of Kentau, as well as some of the newborn skin description in the literature. Changes in living conditions and contamination of household items and skin with mites have changed the color of white race people's skin who currently have no absolutely white and clear skin. Complete recovery of 70 to 95% of patients as a result of the additional anti-mite treatment with thorough elimination of habitat from the mite allergens stated on the leading role of mites in the etiology of their diseases. Therefore, currently Demodecosis is present in all the people as primary or concomitant disease. It means that due of the lack of proper control, Demodecosis is currently present in a variety of clinical masks. In such a situation, the use of anti-allergic drugs is justified pathogenetically, and the use of anti-mite drugs and activities is ethiotropic. It's not for nothing that in clinical medicine allergy is a uniting point, and the use of antihistamines is a pathogenetic principle that unites all the sections of clinical medicine. With no casual treatment and proper control, Demodecosis will progress further, causing an even greater increase of well-known and occurrence of new non-infectious disease, new clinical masks of Demodecosis that has already taken place in some sections of clinical medicine, for example, in rheumatology. Just as each of you sees 5 fingers at each of those around you, so could be seen clearly the objective manifestations of Demodecosis in the skin of all the people I met in all the countries where I had been in the past 7 years. Thus, this suggests that the Demodex mites are definitely pathogenic to humans and cause a self-titled acariasis, clinical masks of which is the form of the non-infectious diseases are now widely distributed in the population. Consequently, the non-infectious diseases is a slow infection inoculated through the skin and mucous membranes, communicating with the outside with an associative complex of pathogens led by mites. At the beginning of the 3rd millennium, Demodecosis is relevant to all the people as a concomitant disease or leading pathology because Demodecosis affected all the people of the world, and it's official medical data. Wherever foot might treat, there are dust mites, and this is also the data of official medicine. So Demodecosis cannot be treated without the participation of clinicians, acarologists, and allergists, immunologists. To eliminate Demodecosis and in clinical masks, it is necessary to consolidate the forces of the population and the medical professionals who need to know the disease clinical findings. In the course of Demodecosis liquidation, recovery will come from atypical and latent types of sarcoptic acariasis. However, for the complete elimination of dermatophagoidic acariasis, which share in the structure of acariasis morbidity, is still insignificant. It's required to develop and implement additional treatment.